Speaking about the wire looping, it was in case of lupus, and it was wire looping of the capillaries, as you can see here. It's this one. Yep. So the capillaries will have a clear areas around them. That's the wire looping. Okay, so diffuse proliferative glomerulonephritis. Well, basically it's lupus, and lupus is a type. Which type of hypersensitivity reaction is lupus? Yep, it's type 2 and type 3. Type 2 for the hematological problem, type 3 for the kidney and the heart problem. Okay. Sharing my screen. Can you see my screen? Excellent. So the next thing is the in immunofluorescence, since lupus is a type 3 hypersensitivity reaction when speaking about the kidney, it's type 3, so immune complex. So on immunofluorescence, is it going to be granular or linear? A granular, excellent. An electron microscopy anyhow. Lupus is weird, really. It affects every single area. It goes subendothelial, subepithelial, and intramembranous. So if the collections of the accumulation are everywhere, think about lupus. So it's an IgG-based immune complex with a C3 deposition. In lupus, the antibody is against what, guys? DNA, not DNAs, it's DNA. Okay, so the next one is an IgA nephropathy, Berger disease. It's an episodic hematuria that usually occurs concurrently with a respiratory or a GI tract infection. An IgA is secreted by mucosal lining, as we spoke about, and it led to creation of lead point in case of intussusception, the telescoping problem. Remember that renal pathology of an IgA vasculitis, it's a vasculitis, so it's a type 3 hypersensitivity reaction. So, on light microscopy, you will see mesangial proliferation, and in immunofluorescence, which is the important one, in contrast to all of the other vasculitides, IgA nephropathy is the only one that can lead to granular deposition. It is the only one, okay? And the deposition will be an IgA-mediated deposition, which is different from the other one because all of them are IgG. This is the only one that is an IgA. Also, in electron microscopy, you will see mesangial immune complex deposition. And now comes the second most important pathology for this page, which is Albert syndrome. The most important one is the acute post-streptococcal glomerulonephritis. Actually, I forgot one thing I should tell you about before keeping going. Guys, an IgA nephropathy and post-streptococcal glomerulonephritis look exactly the same. I'm not speaking about this. I'm speaking about the symptoms. The patient will have a respiratory tract infection, and after some times he will have a bleeding from blood in the urine. Notice episodic hematuria that occurs concurrently with a respiratory tract infection. On the exam, they will do this trick to you. They will give you two options. One of them, acute post-streptococcal glomerulonephritis, and the second one is an IgA nephropathy. The patient had the respiratory tract infection and now is having bleeding from, having blood in the urine. The way to differentiate between an IgA nephropathy and an acute post-streptococcal glomerulonephritis is the time. In the first pathology, it's 2 to 4 weeks, okay? While in IgA nephropathy, it's 1 to 5 days. Please make a note about that. It's less than a week, 1 to 5 days. That's it. But in case of acute post-streptococcal glomerulonephritis, the least is 2 to 4 weeks. Someone make a note about this. This one, 2 to 4 weeks. This one, 1 to 5 days. The bleeding will be after the respiratory tract infection. Okay, so the next one is Albert syndrome. I told you that the mutation will be in a type 4 collagen. It seems like which other type of nephritic syndrome we spoke about that led also to destruction of the collagen in the basement membrane? Goodbaster, yeah. But the only difference between the two, that Goodbaster syndrome was an antibody-mediated pathology, while Albert syndrome is just a mutation leading to a defect in a protein, collagen. That's it. So it's a mutation of the type 4 collagen, and that will lead to thinning and splitting of the glomerulus, which makes it a glomerulus basement membrane, of course. So the basement membrane is the one which will be defective. Why? Well, basically what you are having now is something like this. You have your basement membrane like this. Your basement membrane has collagen inside of it. So you will have a clear area, clear area, clear area, clear area, clear area. And all of these clear areas with no collagen inside of them will be like an openings. So they make it look like a basket. Yeah? So if I enlarge at this glomerular basement membrane, see? Empty area, empty area, empty area. It looks like a basket. I will send you this photo because it's really difficult to find this one, I have to say. Okay. Okay. No, come. Ah, damn it. Okay. Yep, here you go. So this is what? This is Albert syndrome. Okay, let's go back to here. So in Albert syndrome, I hope some of you watched Dr. House because there was one episode about Albert syndrome. If you would like, I can check out which episode it was and I can send it to you. The whole episode is speaking about Albert syndrome from the beginning to the end. There was a child who was deaf. He could not hear. He could not hear. He has a problem in hearing. And his older brother was blind and died as well. And Dr. House came and he wanted to know why these children are dying. And he took one child from the graveyard, and after checking his kidney, he found this basket-like structure, which is totally fake because, come on, the child was dead for 2 years and you was able to take a histology of his kidney. Anyway, away from the drama, the child had this disorder, and he was really careful about it. Why? Because it was an X-linked dominant, which means the mother has gave it to her child, so there is high chance she's giving it to the other child. Yeah, and that's how he saved the day. So mutation of type in type 4 collagen, thinning and splitting of a glomerular basement membrane. Most commonly an X-linked dominant. What does that mean? Let's take a look a little bit about genetics because this is actually important. So it's an X-linked dominant disease, which means if you have the gene, you have the disease. So this is the father. Let's imagine that the dot means that he's sick, okay? It's an X-linked, so it will be on the X chromosome, not at the Y chromosome. So can the father give the disease to his male children? He cannot, because you are giving only the Y chromosomes to the male children, okay? So in male children, we give only the Y chromosome from father and the X chromosome from mother. So he cannot transfer it to his children. What about if the father was sick? Can he transmit it to his daughter? And if yes, what is the percentage of chance he's going to give them the diseased allele? How often will the father give his daughter the diseased allele? This is interesting. You know why? Because actually it's 100%. You are like, what? How dare you? Well, here is the mother. I said his female child. So the mother will give them one X. So this is a daughter. But the father cannot give his daughter a Y. She will be like, what the hell, father? Give me an X, I'm a lady. So she will take the X from father. And that X was diseased. So it will be 100% chance, okay? We need to make you master genetics, guys. There is always a question about genetics. Not a question, questions. So it's 100% chance. That's an X-linked dominant. Okay. A mutation in type 4 collagen, thinning and splitting of a glomerular basement membrane, making you a basket-like shape, which we already saw. Eye problems, they can have retinopathy, okay? And why? Because of the defect of the collagen. And the problem in their lens, it's an anterior lenticonus. The lenticonus, if you look it up on Google, it's really difficult to find, but this is how it looks like. This is a normal lens, but here the lens is protruded inside of your anterior chamber of the eye. This is because of a defect of the type 4 collagen, which actually makes some of the lens structure. And thus, you will have something called lenticonus. Just a second, I have no idea how to find these quickly, so bear with me for a second. Well, maybe like that, no. Okay, basically this lenticonus is when the thing is inside of the anterior chamber, yeah? So, and, okay, come here and send. Yep, it worked finally. Okay, so this is the lenticonus. You must know how it looks like, because regardless of the fact that it's difficult to find in Google, it's asked on the real exam. So this patient so far has a glomerulonephritis, sensorineural deafness, so they cannot see, cannot be, cannot hear a B, okay? So they cannot see, cannot be, cannot hear a B. Cannot see because of the lenticonus. Cannot be because of the glomerulonephritis. Cannot hear a B because they have what? Sensorineural hearing deafness. Sensorineural hearing deafness, we will be speaking so deep about it. I mean, we will speak so much about it, it will become annoying when we do neurology. I will teach you how to diagnose sensorineural hearing loss versus conducting hearing loss using a tuning fork, which you must master for the USMLE. Okay, electron microscopy, basket wave appearance due to irregular thickening of the glomerular basement membrane, because I told you, some of the collagen will be destroyed, and that will make holes of the basement membrane, so it starts looking like a basket. Membrano Proliferative Glomerulonephritis, the last one in this patient. So Membrano Proliferative Glomerulonephritis, it's a nephritic syndrome that is often co-presents with Nephrotic Syndrome. So this is the second syndrome we spoke about that has both nephritic and nephrotic so far. The first one was the Diffuse Proliferative Glomerulonephritis, and now the Membrano Proliferative Glomerulonephritis. So the Membrano Proliferative Glomerulonephritis is both nephritic and nephrotic. It has two types also. It has a type 1 and type 2. So the type 1, it's secondary to hepatitis B or C infection. And this is a must know for the step 1. You must know that the Membrano Proliferative Glomerulonephritis type 1 is caused by type B and type C. Also may be idiopathic, but they will not ask you about this. They will ask you about the type B and the type C, because they want you to be able to correlate diseases with each other. And subendothelial immune complex deposits will occur with a granular subendothelial deposit with a granular immunofluorescence. Well, let's do this actually. Let's take a look at an electron microscopy and try to diagnose Membrano Proliferative Glomerulonephritis, Electron Microscopy. Okay, so here we go. As always, the first thing to do when you take a look at the electron microscopy is what should I do first? The basement membrane. So let's do this. Basement membrane. Okay, next thing. Okay, podocytes or endothelial cells. So here what is more clear, the endothelial cells, but let's try to look for podocytes. Here they are. Yeah, okay, so where is the endothelial cells? Here they are. So the next important question is, where the hell are these deposits? So let's take a look at it. These are the deposits. So they are under the basement membrane, which is under the, like between the basement membrane and the endothelium. So we call it exactly subendothelium. Okay. See, it's not difficult, electron microscopy. They make it sound difficult, but it's not. It's super simple. Just you need to have an algorithm to work with. So, it's a subendothelial immune complex deposits with a granular immunofluorescence. It's a granular, so is it an antibody or a immune complex? Immune complex. I like the fact that you have mastered the concept already, so you are comfortable with it. Oh, granular, that's immune complex. Oh, it's linear, it means it's antibody. It's Pauci, it's neither. So, type 2 is associated with something called the C3 nephritic factor. This is actually sadly important. It's basically an IgA autoantibody that stabilizes something called the C3 convertase. Okay? So this C3 convertase normally is a substance that cleaves and activates your C3. Okay? So you are like, okay, let it activate the C3. What is the big of a deal? Well, when you are persistently activating the C3, you will make, basically, you will start cleaving it. It will start becoming destroyed and depositing in wrong organs where it should not be depositing. So what is happening here, that you have an IgG that is stabilizing the C3 convertase that will lead to persistent complement activation that will lead to less C3 level. So there will be a decrease in the C3 level. There is one more point I need you to know. If this is the basement membrane, the C3 convertase will be here, yeah? And the C3 convertase, as I told you, it leads to persistent complement activation and the cleaving of the complement afterward. So this is the basement membrane, right? Look what it does to it. It cuts it into two halves, okay? So when it cuts it into two halves, it leads to something called the tram track appearance, okay? So let's do this again. You have the basement membrane, good? After you have the basement membrane, this C3 convertase start activating a lot of C3. And this C3 will start accumulating where? Inside of your basement membrane, in the middle of it. When the C3 will come here, obviously there will be activation of the immune system to eat up this portion in the middle. That will lead to two layers of the basement membrane happening, which we call them the tram track appearance. Okay? So, again, type 2 is associated with a C3 nephritic factor. It's an IgG autoantibody that stabilizes the C3 convertase. So you will have persistent complement activation, which lead to reduction of the C3 level. It's an intramembranous deposits, also called dense deposit disease. And where is the dense deposits? You guessed it, it was in the glomerular basement membrane. Yeah? The deposits are here. And after the deposits happen, what I told you happens? Splitting. Yeah? So both type, there will be a mesangial ingrowth, which lead to glomerular basement membrane splitting, leading to the tram track appearance on case of the histology. Let's take a look at some trauma tract appearance. I know that it's actually kind of like in kidney is not difficult, but the problem with it that there is a lot to memorize, like so many pictures. So that's why after the class I will be spamming you with a lot of pictures. So I'll be asking you, what is this? What is that? What is this? What is that? So yeah, stay tuned for all of these questions. Okay, let's take a look. Oh yeah, here it is. Okay, this one is good, but I feel I can find better. Okay, this one seems fine. Okay, so if you enlarge on this one, you can see little spaces here, like little opening between the two structures. For example, there is, here it is more apparent. So you can see here between these two areas, there is like a lucent area. That lucent area is the trauma tract appearance. But still, I'm not convinced with this picture because it's not that good by looking. Oh, this one is excellent. Okay, this one is the one I was looking for. Let me send it to you. Okay, and then I can enlarge on it. Okay, can you see there is like two layers here, like 1, 2, 1, 2. That is the trauma tract appearance. Again, one more. Let's take a look. 1, 2, 1, 2. So that's the trauma tract appearance because the basement membrane has been separated. Okay, so yeah, I like this one much better. Okay, so let's go back to here and see what do we have. So this is it for nephritic syndrome. Now nephrotic syndrome. Nephrotic syndrome is much more easier than the nephritic syndrome because a bit of less memorization, okay? And then the rest of pathology, it's much more easier. Actually, I believe that if we keep going like this, it's pretty easy. We'll finish the whole kidney before the end of this month. And I will explain which one. The Membrano Proliferative Glomerulonephritis do you mean? Okay, so Membrano Proliferative Glomerulonephritis has two causes, okay? So the cause number one is by hepatitis B and hepatitis C infection, in which they lead to a subendothelial deposits. If we imagine that this is your basement membrane, the deposits will be somewhere right here. These deposits will seep inside of your basement membrane, and then your immune system will come and start to want to cut it, yeah? Basically eat up that deposits. When this deposit is eaten, it will lead to formation of this trauma tract appearance. And in case of the other disease, other type basically, which also has a trauma tract appearance, okay? It's associated with a factor that is inherited called C3 nephritic factor. We get it from our parents. This factor, when we get it, it's an IgG autoantibody that keeps your C3 going. So what is this C3 convertase? Where did we see it before? In the future, when we do immunology together, I will be showing you this. See, C3 convertase. When this C3 convertase is hyperactive, it will lead to making of some complements. So these complements will be like C3b, which will deposit inside of the glomerular basement membrane. After it deposits, it will be eaten. After it will be eaten, there will be splitting. And that splitting of the basement membrane will lead to a trauma tract appearance as well. The trauma tract appearance can be seen on histology. As you can see, there is like two layers type of thing here. Two layers. Normally it should be like one layer. It should be like one thing. But here there's two layers. Two layers. So these two layers is the splitting. So let me add. Okay, so also they write that the deposits can be intramembranous, which also called dense deposit disease, and these dense deposits will be consumed by the immune system, which will lead to glomerular basement membrane splitting, and it will lead to tram track appearance and histology. I hope it makes sense now. So now we are going to speak about nephritic syndrome. Nephrotic syndrome. We are done with nephritic syndrome. Nephrotic syndrome, it's much more easier than the first one, I have to say. It's not that difficult, but I saw like they changed something in the new version, so I'm preferring to do it from the new version because of the changes. I don't want you to get like an info a little bit out of date, so you always need to be at the cutting edge of medicine. So nephrotic syndrome, massive proteinuria more than 3.5. So minimal change disease, also known as lipoid nephrosis. Why? Because back in the time when children had it, they used to have a little bit of lipid inside of their BCTs, a proximal convoluted tubule. So they decided to call it lipoid nephrosis. Also, the patient who had it had a really high level of cholesterol inside of their circulation. Why? Because when you lose a lot of proteins, you will not be able to make a lot of apolipoprotein, which will lead you to have hypercholesterolemia. Yeah, it was one of the nephrotic syndrome problem. So most common cause of nephrotic syndrome in children, often idiopathic, but can be triggered by recent infection, immunization, immune stimuli. So this is actually kind of sad, because they like some of these people who are anti-vax come and follow you on this one. You know, immunization leading to minimal change disease. Does it lead to it? Yes, it does. Well, does immunization lead to Guillain-Barré syndrome? Yes, it does. Does immunization can sometimes become active and kill you? Well, that's possible if it was a live vaccine. Should you take the vaccination? Absolutely. Why? To get a minor minimal change disease that will resolve, and to have it actually is a chance of 1 in 50,000. To get that is better than getting measles, you know? To get measles, you will die, and if you will not die, after 10 years, you will get panencephalitis, and there is high chance that you will die. And you cannot prevent it if you get it the first time. Maybe vitamin A will help, but still. So, rarely it can be secondary to lymphoma, and this I want you to highlight. Lymphoma, especially the Hodgkin's lymphoma. The Hodgkin's lymphoma can make some cytokines which can lead to damage of the... What is damage in the case of nephrotic syndrome? Is it the podocyte or the basement membrane? Yep, it's the podocyte. So these cytokines will destroy the podocyte, which will lead to removal of the charge, and the charge was negative. So no negative charge. No negative charge, the albumin will be able to go, and when it goes out, it will lead to edema, that's one. Also, you will lose a lot of immunoglobulin, which decreases your immunity. Also, you will lose a lot of apolipoprotein, which lead you to have hypercholesterolemia. Also, you will lose antithrombin 3, which lead to a hypercoagulable state. So primary disease has an excellent response to steroid, and this is super important because it's one of these diseases that you learn medicine for. It's one injection that gives you a cure. Okay? Light microscopy, it will be totally normal. There is nothing bad there. Sometimes you can see lipid in the BCT, and that's why back in the time it was called lipoid nephrosis. They don't use this name anymore. They use minimal change disease. What is its name? Minimal change disease. So there is minimal change on microscopy. Okay? You will see nothing basically. All good. Immunofluorescence, well, there is no deposition, so it will be clean. Okay, what about electron microscopy? There will be effacement of the photoprocesses. Remember about the photoprocesses? Well, let's do it. When you look at electron microscopy, what is the first step? Basement membrane. Just make it a nature of you guys. It becomes like really easy. You are like, okay, this is the basement membrane and I can see like a few slits here. Yeah, it's visible. There's a few slits. So you know that this area is the Bomis capsule and this is the other area. Exactly. So here is podocyte, but wait a second. Where is the foots of podocytes? They are effaced. So effacement of the podocyte is highly characteristic of minimal change disease, but it's not specific to it, which means there is other diseases that can also have that. But so far, for minimal change disease, the only change we saw so far was the effacement of the podocytes foot processes. Okay. So minimal change disease, young children, not a big of a deal, treated with a steroid, they will go back to normal. Next one, focal segmental glomerulosclerosis. It's the one they kept telling you in high school to prevent you from doing drugs. It sadly higher in some population like the black people, but it also have some relationship, but they don't mostly ask about this, or they don't also ask about the idiopathic one. What they care about is the rare ones, okay? They care about the rare causes. For example, HIV infection can lead to focal segmental glomerulosclerosis, okay? So it's like sex, sickle, and heroin, obesity, interferon treatment, and congenital malnutrition. Let's speak about this actually. So HIV infection can precipitate to it. But guys, in case of HIV infection, you don't have an actual antibody against the kidney, you know. So if that is the case, your immunofluorescence will show basically nothing, yeah? Except in some cases, okay? So in case of sickle cell disease, there is this sickle cell, which looks weird. Can someone tell me what will happen to the ASR in case of sickle cell disease? It will be high or low? Yep, it will be decreased. Excellent, excellent. So, and heroin use can also lead to focal segmental glomerulosclerosis. Keep in mind that this focal segmental glomerulonephrosis is pretty lethal, okay? So, and the other one is obesity, interferon treatment. Okay. Guys, what is interferon is basically like a normal substance that is secreted from one virally infected cells, and when it's secreted, it tells the other cells around it to be careful not to get infected by the same pathogen as well. So it's actually a physiological thing. But we have made it in the laboratory so we can inject it to the patient to reduce the infection rate, you know, and to reduce the severity of the infection. Also, congenital malformation can lead to focal segmental glomerulosclerosis. Okay, and it can be used for hepatitis C treatment. Basically, it makes the treatment faster, okay? But for interferon, you will be surprised. In the future, I will tell you that we use it for the treatment of multiple sclerosis. We use it for the treatment of chronic granulomatous disease. The mechanism I will tell you whenever we explain one of these pathology. Okay, so so primary disease can have inconsistent response to steroid. Well, minimal change disease, perfect response. Focal segmental glomerulosclerosis, really bad response to steroid. And it may progress to CKD, okay, which is chronic kidney disease. So what are you going to see in case of light microscopy? On light microscopy, you are going to see the following. Well, it's focal segmental glomerulosclerosis. Focal segmental. Focal, less than 50% of the glomeruli. Segmental, affecting one segment at a time. Yeah? So you can see focal segmental. Okay, so again, let's take a look at Google, what they write. Focal segmental glomerulosclerosis. Notice, focal area here, area there. This is area is normal. So some areas are pathological, some area are abnormal. We call it focal segmental. So again, come. Okay. Notice this is the focal segmental, and this one focal segmental. Okay, focal segmental glomerulosclerosis. Okay, so the next one, they write, often the immunofluorescence will be negative, but may be positive for non-specific focal deposit of IgM, C3, and C1. Basically, what you need to know that it will be negative. Pretty rarely it can be positive. You are not required that much to know it for the exam. For electron microscopy, you will see the same thing you saw in minimal change disease, which is effacement of the photic processes, okay? And now the membranous nephropathy. So membranous nephropathy is the second disease related to lupus. So we spoke about lupus before in another disease, which was the diffuse proliferative glomerulonephritis in the previous page. Now we have another disease that is associated with lupus. The first difference between the two, that in diffuse proliferative glomerulosclerosis, it was both nephritic and nephrotic syndrome, while in membranous nephropathy, it's solely nephrotic syndrome. So in case of a patient with lupus, if he's bleeding, if he has a hematuria, think about the previous page. If he does not have a hematuria, think about the current page. Okay. So they write, also known as Membranos Glomerulonephritis. It can be primary due to antibody to the phospholipase A2 receptor. Does anybody here know what is phospholipase A2? Which drug work at phospholipase A2? There is a drug really commonly used actually, lead to inhibit phospholipase A2. No, it's not NSAIDs, no. NSAIDs inhibit cyclooxygenase. It's really commonly used, but actually I have to say it's in the same pathway as NSAIDs. Niacin, no. It's actually steroids, guys. Take a look. If you check the pathway. If you take a look at how the archaeodontic pathway goes, first of all, come on, open. First of all, you have the following movement. Yep. So you can see from the membranous phospholipid, we have some phospholipase A2, which is the antibody is against in case of membranous nephropathy, and also the steroid works at it, okay? And then archaeodonic acid is made. We have the COX where NSAIDs work, and we have the lipotrienase pathway, lipooxygenase basically to the other side. So yeah, keep in mind that this phospholipase A2, steroids work there. Okay, so antibody to the phospholipase A2 and or to drugs. For example, so just a second. Here they write it can be antibody to the phospholipase A2 or secondary to drugs, like someone getting a drug and then he gets a membranous nephropathy, like NSAIDs, penicillamines, or gold. Do we use gold for a treatment of any disease? Well, actually, gold can people can get they can use gold for a treatment, but I like this. It's expensive, but gold prices are dropping first time in a century. But really, if we speak about gold, gold has been used for a treatment of skin problem. Also, in the future, you will see that it's used for a treatment of rheumatoid arthritis. We'll speak about this when we do MSK. Gold is used to treat rheumatoid arthritis. Okay? So, but really expensive treatment, I agree. So infection also can lead to membranous nephropathy like hepatitis B, hepatitis C, and syphilis. Here they come again. So hepatitis B and C, we spoke about them in case of the Membrano-Proliferative Glomerulonephritis. And here we see them again in the Membranos Nephropathy. Okay? So also we have lupus and solid tumors. So primary disease have a poor response to steroid. Why? Because the freaking receptor of a steroid is destroyed. And it may progress to CKD. So the receptor of a steroid was the phospholipase A2. He's not working. So the response of steroid is minimal or absent even. So if you take a look at their, it's membranous nephropathy. Remember, the word membranous means thickening of the basement membrane. So there will be diffuse, capillary, and glomerular basement membrane thickening. Basically, it looks like this structure is not having its place, you know, like there is no spaces in it at all. I mean, how is the urine even able to exit from these vessels? It looks so stiff. And in immunofluorescence, since it's actually an immune complex deposition type of disease, so it will be granular, and it will have something called the spike and dome appearance subepithelial deposits. Subepithelial, so are they are under the podocytes. But here is the thing, they go up and down, up and down, up and down, okay? So we call it spike and dome. So if we speak about amyloidosis, amyloidosis is kidney is the most common involved organ with systemic amyloidosis. Why? Because it clears all of it out and it gets stuck into it eventually. It's associated with, well, it does not clear the amyloid itself. It like it clears the substance who make the amyloid, like the AA amyloid or the AL amyloid. That's why you get amyloidosis in the kidney. It's associated with chronic condition that predisposes to amyloid deposition, like an AL amyloid. And a really smart student will tell me, in which disease did we get an AL amyloid? Excellent, multiple myeloma. I'm asking about systemic, not localized. It's my mistake, I should have said systemic. Okay, what about AA amyloid? AA amyloid. Chronic inflammation. Is osteoarthritis a chronic inflammation or not? Osteoarthritis, itis. No, it's not. It was misnamed basically. It's a degenerative disease, but it was misnamed as an osteoarthritis, which is not correct. Okay, so then prolonged dialysis. Which substance lead to creation of amyloid in case of dialysis? Okay, so during dialysis, there is one substance that basically the dialysis machine cannot get outside of your body. I was asking about it, but since you asked me back, that's a fire back. But okay, it's this one, mercaptoglobulin. Mercaptoglobulin. Where are you? Come on, come on. Yes, microglobulin. And what is this microglobulin? When we do the immunology together, we will see that there is something called the MHC, major histocompatibility complexes in our cells. These MHC class 1 are located in every single cell of your body. So they will be cleared out during dialysis, except one portion, which is this one. So this microglobulin will be accumulating inside of your tissues as a misfolded protein, because it's a protein, and it will be accumulating in the extracellular space, leading to amyloidosis. Okay, so let's take a look. Guys, when you start like checking something out in a system and you start from the last page to the first page, it means that you are almost done. So, okay, kidney is the most common involved organ. We spoke about this, we spoke about dialysis. So in light microscopy, in the Congo red, it will show, you will see it, you are able to see it in a non-polarized light that is called Congo red. Also, you will be able to see it in polarized light, we call it that apple green. Okay, due to amyloid deposition inside of the mesenchyme. Let's take some looks at some amyloid in the kidney. Okay, so this is the Congo red. You can see accumulation of the amyloid. And is it intracellular or extracellular, guys? Yep, it's extracellular. Okay, so if we speak about the apple green birefringence, it's basically a technique in which we stain and then we put it under polarized light and it looks something like this. Okay, so here you go. So the next thing we are going to speak about is here. Okay, so the last topic for today, diabetic glomerulonephropathy, is the most common cause of end-stage renal disease. Yep, a lot of people in the US have diabetes. Anybody knows why? Fat food? No, it's fast food. Okay, so diabetic glomerulonephropathy. So it's most common cause of end-stage renal disease in the US. And let me first of all tell you what happens exactly during this problem. Oh, okay, that's true. So you have your afferent arteriole, you have your glomerulus, you have your efferent arteriole, okay? So during diabetes, the first area to be destroyed is which one? Anybody knows? What is the first area to be destroyed in your kidney? Afferent, efferent, or glomerulus? Actually, it's the efferent arteriole to be first destroyed. You are like, what? Efferent? Yes. Well, if your efferent is the first to be destroyed, what happens to your GFR? Basically, when it's destroyed, there is less perfusion through it, so it will go up. Your GFR goes up. Well, you are like, amazing. So this diabetes actually increase our GFR, which improves our kidney function of increasing filtration. It increases filtration, yeah? More GFR mean increased filtration because the filtration fraction formula says the GFR divided by the renal plasma flow. So the renal plasma flow in this case is pretty low because less perfusion to the efferent arteriole, while the GFR is pretty high, so the filtration fraction will be high. That means diabetes is perfect for us. Not really. Well, it's true. The filtration fraction will be high, the glomerular filtration rate will be high, and the renal plasma flow will be low initially. So in the beginning of this disease, your efferent arteriole will be the only area affected by the sclerosis, which is due to the diabetes. But after some times, your glomerulus itself will be destroyed. So if I wanna make a graph, and down here write time, and on the side here write the GFR. So initially, it's true, your GFR will go up. But by the years, it will start deteriorating, going back until the patient dies. But to be more fair, the GFR starts from here and go up there and then goes like this, okay, until the patient dies. So again, your GFR is here when you have sclerosis of your efferent arteriole, it goes up here, then it goes down until the patient dies. So they write, most common cause in the US, hyperglycemia lead to non-enzymatic glycolation of the tissue, leading to mesenchymal expansion, glomerular basement membrane thickening, and increased permeability. As we spoke about the first region to be affected, what is it, guys? The first region to be affected? Efferent arteriole, thus a hyperfiltration will occur. Glomerular hypertension and increase in the GFR will be, and all makes sense. So there will be, if you have constant filtration through the glomerulus, your glomerulus is working overtime. So you will have a glomerular hypertrophy and a glomerular scarring, which will eventually lead to glomerulosclerosis, which will destroy your GFR. So that will lead to further progression of nephropathy. Keep in mind, initially in a diabetes, your GFR goes up, then it goes down even worse. So in light microscopy, mesengial expansion will be seen, a glomerular basement membrane thickening will be seen, but they do not really care about that on the exam. What they care about on the exam are these guys, the Camillus-Steel-Wilson lesion, which are these. Eosinophilic nodular glomerulosclerosis. If you see, there is a pinkish material accumulation inside of your kidney. This is called the Camillus-Steel-Wilson lesion. The moment you see these, done, you have a diagnosis. This patient have diabetes for a really long time. Okay, so let's copy these, take a couple of look at a couple of them, and we call this session off for the day. Okay, so you can see them accumulating here. And you can see them accumulating here. One is here, one is here. The moment you see it, it means diabetes. You can see them accumulating here. And that's it for today. I hope you liked our today's session. We are pretty much more than halfway through renal. What is left is not that difficult at all. You just need to believe in the process, and pretty soon we'll be done with the whole thing. Like we have, excellent. My screen is stuck? Oh, okay. Well, anyway, we are done for today. Okay, yeah, of course I can send the last picture. Just a second. Okay. I send one marked and one non-marked. Okay, and this is pretty much it. If you have any other question, please contact me and we can keep doing it. And see you guys tomorrow. Bye bye, everybody.
Kahve